Hello everyone. Today I am going to tell you easily how to approach a patient who presents with heartburn. Heartburn is typically described as a burning sensation in the retrosternal area, most commonly experienced in the postprandial period. It is considered troublesome if symptoms occur 2 or more days a week. The most common cause is gastroesophageal reflux disease, GERD for short, which classically presents with heartburn and/or acid regurgitation. Not every patient who presents with these classic findings needs additional testing. An 8-week trial of PPI is sufficient. However, specific alarming signs warrant investigation. They include new onset of dyspepsia in patients is greater than or equal to 60 years of age, hematemesis, melena, anemia, unexplained weight loss, dysphagia, which means difficulty swallowing, adinophagia, which means pain on swallowing, and persistent vomiting. The presence of anyone should prompt urgent evaluation with upper gastrointestinal endoscopy within 2 weeks. Another indication for endoscopy is persistent typical symptoms despite optimal treatment with proton pump inhibitors, PPI for short, for 8 weeks. The differential diagnosis for GERD includes infectious esophagitis, eosinophilic esophagitis, pill esophagitis, which occurs commonly due to some pills such as non-steroidal anti-inflammatory drugs, NSAIDs for short, and motility disorders such as achalasia. For this reason, at least, biopsies should be taken from the esophagus, even if the mucosa is looking normal, to exclude eosinophilic esophagitis. Now, if the endoscopy is negative and no evidence of reflux esophagitis exists, the next step is to perform esophageal pH monitoring. Esophageal pH monitoring is performed by inserting a thin tube through the nose or mouth into the esophagus, where a monitor attached to the tube measures the acid level, pH, over 24 hours. Another method involves using a wireless pH probe, like the Bravo pH monitor system, which is attached to the upper esophagus lining with an endoscope. This device measures acidity and transmits pH levels to a recording device worn on the wrist. The capsule falls off after 4 to 10 days and is expelled through bowel movements. According to the pH results, 4 different scenarios are expected. The first one is that the patient has residual acid reflux. Such patients may benefit from alginates such as Gaviscon or twice-daily doses of proton pump inhibitors such as pantoprazole or a newer agent as vonoprazan, a potassium-competitive acid blocker. Famotidine, a histamine 2 receptor blocker, may be added at bedtime. Patients who do not respond should be given a trial of baclofen for 3 months. Baclofen is a GABA receptor agonist. It targets the underlying mechanisms of GERD by decreasing transient lower esophageal sphincter relaxations and increasing postprandial lower esophageal sphincter pressure. Finally, anti-reflux surgery such as laparoscopic surgery may be considered. The second one is that the patient has non-acid reflux. This means that a substance other than gastric acid is the cause of the symptoms, such as bile. In these cases, baclofen is given to inhibit the reflux by the previously mentioned mechanisms. The third one is that the patient has reflux hypersensitivity. Normally, there is a physiological degree of reflux that occurs in healthy individuals and typically doesn't cause symptoms. However, in such patients, this physiological reflux triggers symptoms of GERD. Those patients may have a partial response to proton pump inhibitors. But adding pain modulators such as nortriptyline, amitriptyline, both tricyclic antidepressants, or citalopram, fluoxetine, both selective serotonin reuptake inhibitors, results in improvement in such patients. The final one is functional heartburn. This patient typically has heartburn with normal endoscopy findings, normal pH results, and no motility disorders detected on manometry. This category of patients does not respond to PPI, except in very few cases. Pain modulators are the preferred agents for them. Let's recap. Heartburn is commonly caused by gastroesophageal reflux disease, GERD. While a trial of proton pump inhibitors, PPIs, may suffice for typical cases, alarming signs warrant urgent endoscopy. If endoscopy is negative, Esophageal pH monitoring can identify acid reflux, non-acid reflux, reflux hypersensitivity, or functional heartburn. The differential diagnosis includes infectious, eosinophilic esophagitis, pill-induced esophagitis, and motility disorders like achalasia. Esophageal biopsies are recommended regardless of endoscopic findings. Treatment depends on the underlying mechanism, with PPIs, baclofen, surgery, or pain modulators as potential options based on test results.